Hi, this is Nick Williford and Manos Brilakis presenting case 194 for the Manual of Percutaneous Coronary Interventions. This is a case of complex PCI with Impella hemodynamic support. The patient was an elderly woman with an ejection fraction of 15% who was an inpatient on milrinone. She had an occluded right coronary artery and significant disease on the left, but had a viability study that showed viability in the LAD and the circumflex territory. She also had significant peripheral arterial disease with inability to use femoral access, and she was referred for complex PCI with hemodynamic support. Given the PAD, there was a surgical cutdown on the right subclavian artery, placement through a graft. Through the graft, an Impella CP was advanced into the left ventricle, and then with single access, a 7-French sheath was inserted there as well. Getting the Impella in was fairly challenging, requiring using an AL1 catheter to be able to direct the guide wire into the left ventricle, but eventually it was successfully done. Usually we do use a pigtail, but in this particular case, again, we had difficulty. The pigtail would not advance. And then by essentially screening the aortic valve, then eventually we're able to get the wire in and advance the Impella. We had a lot of difficulty also advancing a guide to the ostium of the left side. Eventually, we pushed a wire with the guide being suboptimally engaged, and the wire did go into the coronary artery. This is an example of the airmail. And then using that wire for support, we were able to advance the guide along with the guide extension slightly into the coronary artery and take a picture. We do see that there is some disease into the ostium of the LAD. And this is again the LAD going down. The wire goes into diagonal. There is a large branch on the top. So some more injections showing again a severe, looks like distal left main disease with diffusely diseased LAD. But the view that actually provided the most information was the araeocranial, in which we were able to see clearly that the patient has a severe ostial LAD disease. There is a significant ostial diagonal disease with a very large diagonal. There's some disease in the mid-LAD as well as the ostium of the LAD, and a 90% disease in the ostium of the circumflex with slightly decreased flow. Also, there was a significant lesion in the distal left main. So how to deal with this? Essentially, we have two bifurcations, LAD diagonal as well as the circumflex. Before doing anything, we used this projection to advance a guide wire in the remaining of the vessels. This was engaging the circumflex with a guide wire. It was a workhorse wire. The diagonal was challenging to get to, but eventually we were able to use a Sasuke dual lumen microcatheter, and through the Sasuke we were able to advance another workhorse wire in the diagonal branch. We then did intravascular ultrasound. This is into the LAD, showing some diffuse disease distally, not severe calcification. This is the wire coming in from the diagonal. And then there is significant calcification in the ostium of the LAD before coming into the left main. We also did intravascular ultrasound of the diagonal. Again, some diffuse disease distally. The vessel is larger, more proximally. This is a significant left main disease. We also had this very small ramus branch that was essentially almost like a CTO. The wire had a hard time getting through. But eventually, we were able to advance a small balloon, a 1.5 millimeter balloon, and through this, we advanced the guide wire distally and did balloon angioplasty with a Takeru balloon. So the next question is how to approach this. And of course, we need to make sure that the vessel expands, especially the left main ostial LAD that had heavy calcification. So we did use balloon into the LAD as well as a diagonal. This is a kissing balloon inflation with 275 balloons. And the balloons seem to be expanding and the ostium of the left main seems to be expanding. So we have the LAD wire, diagonal wire, ramus wire, and circumflex wire. And then we left the balloon into the LAD. We treated the mid-LAD as well, using the balloon as a reference for the length of the lesion that needed to be treated. Balloons seemed to expand well. both in the mid-LAD as well as the proximal LAD, and the same was true for the ostium of the diagonal branch. We also ballooned the ostium of the circumflex that also seemed to expand. So now we are at the stage where we have predilated the LAD, diagonal and circumflex, and the question is, how do we deal with two sequential bifurcations? The simplest approach would be to get a stent and do provisional stenting from the LAD all the way to the left main, but there's concern obviously for the ostium of the diagonal branch, and there's also concern for the ostium of the circumflex. So what we decided in this case is, given the favorable angle, very open angle on the circumflex, to do T-stenting. So we placed the 2.4 by 12 millimeter drug-eluting stent that expanded well, and we have a nice result into the circumflex. And then when it comes into the LAD, we decide to try provisional and see if that would not compromise the diagonal, of course leaving the diagonal wire in place. This is a 2.75 by 48 millimeter drug-eluting stent, all the way from the left main to the mid LAD, and the stent was successfully deployed. It did expand nicely, which was wonderful, but unfortunately we did have compromise of the flow into the diagonal that is significantly slower now. There's also a nice step up, step down, distal to the stent into the LAD, but no dissection on the IVUS. So we did proximal optimization with a 3.5 millimeter balloon, which also expanded nicely. And then using the dual loop microcatheter and a workhorse wire, we were able to advance the wire into the diagonal. It was extremely useful here to have the previous wire as a marker of the location of the diagonal branch, and then the wire could be advanced. We removed the jailed guide wire, and then we first tried with balloon angioplasty to see if we would get any good result into the diagonal branch. But unfortunately, it didn't look that great. This in the middle part, the ostium looked okay, but the middle part did not look that great. So we decided that we needed some additional treatment into the diagonal branch, and we did an intravascular ultrasound as well that did demonstrate some plaque, some significant diffuse disease. There's some calcium closer to the ostium, and then we're into the left main that looks good with some stent malapposition. For this lesion, we decided to use the TAP, TN protrusion. So we have a stent that goes from the diagonal, barely protruding into the LAD and the left main, and we have a balloon already into the LAD from the left main. That stent was deployed. While the stent was deployed, we take a little puff, showing that we still have some flow into the LAD. And then we brought the balloon back, and we did kissing balloon inflation, and that provided a nice result. And this is the intravascular ultrasound coming from the LAD back to the left main. We do see fairly good expansion, and the same is true for the left main. This is the angiogram. Again, T3 flow LAD, diagonal, and circumflex. There's also flow into this small ramus branch. The patient did well. She was decannulated 2 days later, and then she has been improving. Several lessons from this case. The first one is the importance of support. This is a patient with very low ejection fraction, who has an occluded right coronary artery and has significant disease in all three remaining vessels. So using hemodynamic support is important to be able to do this without adverse events. And in this case, because of the peripheral disease, we had to use a cutdown. Using the Impella CP, it was a small lady, we were able to get enough support to do the procedure. During balloon inflations, there was a flat line. The flow was maintained only through the Impella. Second, about engaging difficult coronary arteries, sometimes the air-mail technique, having the guide as close as possible and advancing a guide wire in a coronary, can work as it did in our case. Wiring side branches can be a problem, especially when there was significant disease, like in the ostium of the diagonal branch. So what we did is use a dual lumen microcatheter that helped direct the guide wire into the side branch. And then in this case, we did do a combination of bifurcation techniques. We did use the T and protrusion technique for the diagonal as a bailout after standing across it and having compromise of the ostium, and we used T-stenting into the circumflex. So in all bifurcation, it's good to hope for the best, but it's important to also prepare for the worst. Having a guide wire into the diagonal was very important to make rewiring of the vessel relatively straightforward using the dual loop microcatheter and allow stenting and achieving good undergrade flow. Thank you.